Good evening, everybody. This is Sean Hall. I'm president and founder of the Life and Breath Foundation. We are very happy today to have a special guest with us, Dr. Raj Dasgupta from USC out in California. He's going to join us, and we're happy to have him. And we have a couple things on tap for our topics this evening. We're going to go through and talk a little bit about vaccines, knowing that COVID-19 has really done something to us as we have navigated the last 12 months, 9 months out there. So we're going to get into a really nice discussion on the vaccines. And we've been able to get some of your questions pertaining to that, pertaining to COVID-19, and especially those of our patients that have sarcoidosis. We're also going to have some discussion on how this may affect you. Again, the Life and Breath Foundation was started in 1996. Our primary goals are to offer our sarcoidosis community effective tools to track their journey, decipher medical issues, and maximize the quality of life of our patients, to provide a nurturing environment for those affected with sarcoidosis to share their experiences. And lastly, to build more awareness within our medical community to help combat this chronic disease. Just a apropos time to introduce Dr. Raj. Good evening. How are you?
Hey, Sean, how are you doing? So let me just throw this out here. This is really a special event for many reasons. And I really want to thank the Life and Breath Foundation to actually let me tape this show, because this is going to be a live broadcast of the Dr. Raj Show. But don't worry, Sean, I'm not going to change my voice. It's going to be the same voice. So I'm going to break the fourth wall and do my Dr. Raj Show introduction, and then we'll go right back to answering those questions. So here's the awkward moment, everyone. Hi, and welcome to the Dr. Raj Show. And what is the Dr. Raj Show? It's about being yourself. It's not only about medicine. It's about addressing all things that pertain to wellness, good health. And of course, right now, we cannot skirt around the issues of COVID-19. So I'm very excited. And what makes me so happy about this show in particular, I don't get to talk a lot about what are my passions as a doctor. And one of my passions is taking care of sarcoid patients. Sarcoidosis is my jam. And I actually run a sarcoid clinic here at USC. And I love being part of this Life and Breath Foundation. Sean, who's the CEO of this, is just an amazing person and allowed me to do this. So it's the best of both worlds. It's a Dr. Raj show, which, yay, I love. And I get to talk about sarcoid and COVID-19. So with that being said, Sean, back to you.
Well, Dr. Raj, thank you very much. We're happy to be a part of your podcast this evening. So if we could start, let's start with exactly what is a vaccine?
Sean, great first question. So when we think about vaccines, how do I put it this way? Is that we give individuals, parts of a bacteria, parts of a virus, parts of an infection. And what we do is that we let the patients actually create their own antibodies. So with that being said, let me take a step back, because I always feel it's always hard to describe things. So let's talk about immunity. That's the real answer. Immunity has two branches: active and passive. When we talk about active immunity, there's two ways to get active immunity. One is that you're infected with some kind of bug and you develop antibodies. The other type of active immunity is this vaccination. And what are vaccinations? You give parts of those bacteria, parts of those virus. Usually those parts are inactive or very, very weak, and you make your immune system work. You make them make those antibodies. Now, remember, when we talk about vaccines, they are not antibiotics. They do not treat anything. So, when we talk about vaccines, what vaccines are doing is telling you that if you get infected by that virus or that bacteria, that you know what, Sean, you're not going to die, that you will get just milder symptoms that time. And let me just compare that to the other type of immunity, which we call passive. Passive immunity just means that, you know what, I'm just going to give you antibodies against coronavirus. And there are these, what we call monoclonal antibodies out there, which your immune system's doing nothing. It's actually being lazy. I'm just giving you the antibodies. And they are FDA approved for a treatment of certain people who have COVID-19. So those are traditionally what vaccines are. They're giving parts of a bacteria or virus to let your immune system work and make those antibodies.
Fantastic. So with that said, what is the COVID vaccine?
Oh, great answer. So, of course, everything has to be different when it comes to COVID, right? So, we're talking about a new technology. The technology we're using for the COVID vaccines are right now what we call messenger RNA vaccines. Messenger RNA vaccines. Maybe if we have time, I'll talk about the other type, which is called a viral vector vaccine. But what are messenger RNA vaccines? Well, basically, it's targeting a very specific protein on the surface of coronavirus. It's called the spike protein. Now, remember, corona, the word means crown. So it's actually going to be the spikes on the surface that form that crown. So when you give a messenger RNA vaccine, what happens is that my own body will use the messenger RNA as a blueprint, and I will make antibodies against that spike protein, because it's those spike proteins that allow the coronavirus to get into our cells and cause all that damage. So right now, there are 2 messenger RNA vaccines that are approved, are out there. One is the Pfizer vaccine, and the other is the Moderna vaccine.
Awesome. And how do they differentiate?
Oh, you're okay.
You
You're
know,
putting me on the spot right there. So when we talk about these 2 vaccines, let me just say they're both messenger RNA vaccines. They both are targeting that spike protein I mentioned about, and they both are 2 shots. So when you take the Pfizer shot, you have to do the second shot around 21 days later. If you get the Moderna vaccine, you get the second shot about 28 days later. And both vaccines were actually studied in a variety of races, which I really, really like. And it's also studied in both genders, which is really, really good. And both vaccines are 95% efficacious. So when people ask me, Dr. Raj, which vaccine I should take, I look them in the eyes and say, it doesn't matter. Just take the vaccine. But what are going to be some of the differences about it is that, the Pfizer vaccine, I mean, it has to be stored in freezing temperature. And that's why usually university settings like a USC could have the technology to store it there. The Moderna vaccine could be in your generic freezer. So it's more of a community vaccine. So I could see them getting it more out to the community. Both vaccines were not studied in pregnant women. I just want to let you know that. And both vaccines were not studied in pediatrics. If you want to know when can you get the Pfizer vaccine, it's for 16 years of age and older. For the Moderna vaccine, 18 years of age and older. And those are the main differences. Great question, Sean.
wow. Thank you for that. That was good.
It was a lot. It was a lot.
Yeah. Wow. You did a fantastic job. I'm gonna throw another curveball.
Okay.
I've heard that there is a one-time vaccine out there by Johnson and Johnson. Do you have any information there, how that one works, and especially, in comparison to the 2 you just mentioned?
Now, Sean, I didn't know you're going to be studying for this interview. That's not fair. So you're right. So remember when we're talking about the different types of vaccines for COVID-19, I said on one side we have messenger RNA vaccines. There is another technology called a viral vector vaccine. So bear with me. A viral vector vaccine, that's a tongue twister, is basically using a virus that doesn't really make us feel sick. And in fact, I believe they're using a virus called adenovirus. And this adenovirus, even though humans can get it, they're using one that was transferred in chimps, if I heard correctly. And what happens is we use this virus and we put the messenger RNA inside the virus and we send it in. So it becomes a viral vector. And there are actually 2 pharmaceutical companies, I believe, that are really taking the forefront to come up with these viral vector vaccines. On one side, it's going to be AstraZeneca, and they've been teaming up with Oxford University, which is in the UK. And in fact, I'm sure if we throw on some CNN or BBC, they're actually giving that vaccine out in the UK right now. But that is a 2-dose vaccine. So the other company is actually, like you said, Johnson and Johnson. And this is such a hot topic because not only are they using this viral vector vaccine, their claim to fame is you could only have to give it once. Now, just being a clinician, that just sounds great because of the fact that, I mean, what about compliance? My patients sometimes can't take their nightly meds, and to come back and take another vaccine in 21 days or 28 days and put it on the clock and getting there, it's a lot. So if you can get the job done in one shot, I'm all on board. And some of the initial data for that vaccine are throwing out numbers like 90, 95% efficacy, which are the numbers that we're getting when we talk about the Pfizer and Moderna vaccine itself. And another thing that I heard about, and this is a lot of hearsay, but I heard that the vaccine doesn't have to really be stored at any crazy temperature. You know what I mean? And that is great. So once again, easy to distribute. And also, I heard the shelf life of this vaccine is much, much longer because, when we talk about Pfizer vaccines and Moderna vaccines, once you crack them open and you thaw them out, there's a stopwatch on how long you have to inject someone. So the longer you have, the better it is. I'm not telling anyone out there to go buy Johnson and Johnson stock, but I'm just saying keep an eye on it. It's going to be a really good thing for all of us to have more options for vaccines.
Awesome. Are there any concerns with sarcoidosis patients with getting the vaccine?
Oh, this is the question I've been waiting for. So, of course, when we talk about my beloved sarcoidosis patients, there is very limited concern. In fact, I want you to think about, I need the vaccine. I need the vaccine because we know that sarcoid affects every organ in the body. I know you know that, but what is that organ that affects the most? It's got to be the lungs, and most of my sarcoid patients have lung involvement. And we know COVID and sarcoid they go to the same school. This COVID could affect every organ in the body, especially the lungs. So the answer is that no matter what sarcoid you have, you're going to be at a little disadvantage if you get COVID-19 because you got that initial inflammation and damage in your lungs. So no matter, what medications you're going to be on, no matter how much prednisone you're on, no matter how sick you're going to be, you want to get that vaccine. Now, remember, the COVID vaccine is right now it's a messenger RNA vaccine, and that's good because we're giving you no parts of the virus. It's not a live virus. It's not a partially alive virus. It's giving you messenger RNA. So you cannot get COVID from getting that vaccine. Now, Sean, bear with me. I just want to make sure I mentioned this. So when we talk about sarcoid patients, you guys are on so many medications. There's a methotrexate, there's a hydroxychloroquine, there's a Celsep, an Imuran. There's one medication that doesn't worry me, but I think this is the hottest topic in the whole world, and you hear it from me. Has anyone out there heard of a drug called rituximab? Has anyone heard of a drug called rituximab? Someone out there is going to call me on my cell phone or call you, Sean, but rituximab is not the most common drug I use with sarcoid patients. It's kind of like a second or third line drug, but we do use it. Rituximab is used in the hematological world for certain disorders. It's used in the rheumatological world for other things. And how does it work? It works against B cells. So what does it mean if you work against B cells? B cells actually make antibodies. So I'm going back to basic science. I apologize. There's T cells, then there's B cells. B cells make antibodies. So imagine this, if you're on a drug that blocks the B cells, that means you're not making antibodies. So if I give you a shot of a vaccine, I don't care what vaccine I give you, if I'm blocking your B cells, you're not making antibodies. And that's the only time, I'm not saying that means you can't get the vaccine, but you're not going to get the benefit from it because you're on a medication that blocks the antibodies. So everyone's going to ask me, what do I do? What do I do? What do I do? The answer is we don't know just yet because, obviously sarcoid is an orphan disease. Rituximab is not what most people are going to be on, and we're trying to get the data of what to do. So, of course, I did some research before coming on here and talked to other individuals. So, number one, if you're on rituximab, talk to your doctor. You don't need to stop the medication, but maybe we could think about the timing. It's usually given every 6 months, and maybe what we can do is try to get you the vaccine right before your next dose. So the drug is almost out of your body, then you can make the antibodies, then think about dosing it again. Or what my wife does, because I always love my wife. She's the rheumatologist. She may actually put her patients on a course of steroids for a while to take off the rituximab, get the vaccine going, make the antibodies, and then think about going back on the rituximab. So that's the only medication that, it doesn't prevent you from getting the vaccine, but it may not work. People are going to ask me, well, how do I know if it works? Well, in a perfect world, if everyone had access to every testing, you want to test for the antibody after you get the vaccine, and hopefully you will be positive for the antibody.
Fantastic. Wow.
That was a long one. That was a
long one. Yeah. So there's a question that came up that I wanted to share with you. We have a patient that wants to know, are there any side effects that could come up with people that have allergies?
Oh, wow. Of course, this is a great question and a very timely question. So right now, we know from the studies that we had, and I believe when they were initially doing the studies on the Pfizer vaccine and they were doing studies on the Moderna, there were some individuals in the UK, in the United Kingdom, that developed anaphylaxis when they got some of these vaccine doses. And I think that really made it out on the news and the media extensively. And, I think it did kind of cause a little panic, about this. And the truth is that when you're giving out vaccines in the hundreds of thousands, when we're giving vaccines out in the millions, having 2 cases of anaphylaxis, I hate to say it, it's expected. And, number one, the individuals who had anaphylaxis, they're doing good. So I want you to know that. And I don't want to downplay anaphylaxis because I am a critical care doctor, and anaphylaxis means very low blood pressure, even trouble breathing, and it definitely is scary. But, there was a study in 2015 in the United States, and it actually looked at all vaccines that we were giving, and specifically looked at the incidence of anaphylaxis. And you know what it found out? The incidence of anaphylaxis is like 1 in a million. So, I would not let these cases prevent you from getting the vaccine. But there is a huge but. We still need to study this vaccine to talk about these allergic reactions. What part of the vaccine, what part of the solution, why are we allergic to it? But if you tell me right now, I carry an EpiPen, I'm allergic to shellfish, I was allergic to the flu shot. You know what, Raj? What? I'm just allergic. I'm just an allergic person. No, I would not get the vaccine if you have a lot of allergies at this point, because I do worry about you. And that's probably how I would approach it for those who ask about allergies and the vaccine.
Gotcha. Very good. Very good.
I know. I feel like I'm getting graded after each response, like a lever that goes up and down.
I think you're doing very well. It's being well received, and again, we appreciate you taking the time to really help educate. One question came in: will the vaccine be effective in preventing other variations of COVID-19?
Well, it seems like everyone who's watching today really has the CNN on all the time because they know exactly what to ask.
Right on top of it, right?
So we're talking about these variants are going to be out there. And the truth is that if you ask me in kind of like, broad strokes, am I happy there's a variant out there? Of course I'm not, you know what I mean? But the reason why there's variants right now is because we as a country are not doing our job. And what's our job is to actually get that herd immunity, to get this virus under control. And I'm blaming myself. I'm blaming everyone, because we know what we need to do. We need to do the big 3: good hand hygiene, social distancing, wearing the mask, and even though we think we're doing it, we're not. People are still traveling and having social get-togethers. I'm not judging, I'm just saying. And that's why I know it's getting worse and worse and worse. And it's not a surprise. When is it getting worse? After Thanksgiving, after Christmas, after New Year's, in the winter months, when we get together, during family events. It's a setup. It's not a coincidence that we're shooting up. And the more we don't control this virus, the more it spreads, the more variations you're going to get. This is just a natural course of a virus. You're going to get the word, I'll say the word, mutations. You know what I mean? That's what happens. And the good news, I guess there is good news, is that from the studies I heard so far, that this new variant that we're talking about, and let's be, even more specific, there's more than one variant out there. I don't want to be Debbie Downer and make everyone cry, but there's more than one variant. The variant that most people ask me about is the UK variant. And there actually is a new variant now that they just found in Ohio, which is scary. And how do they know that is because they're now genotyping these viruses to see exactly what is the fingerprints of each virus. So the UK variant, which is the first one we were worried about, why we have all these travel bans from other countries coming in, actually didn't show to be more deadlier than what we have. It's more easily infectious. I mean, I guess that's better. It's scary. And this is why if you have a virus variant that's more infectious, well, then now more than ever, it's not time to let's reopen this and let's get together. I mean, it sucks. I mean, having all this isolation stinks more than anything, but this is what's going to happen if it's more contagious. And you got to wear the mask. You got to staple that mask on us and wear those gloves and social distance. That's only going to do it. But I know that Pfizer has now been testing their vaccine on the UK variant, and it shows that it's so far effective. So I could say that with good honesty. I don't know what the Moderna data is, but I know they are going to be testing it on the UK variant. But like I said, there are other variants out there. They're here in the States. And so once again, the only way we're going to stop getting these mutations is by flattening the curve and actually really, taking to heart what I just said, good hand hygiene, social distancing, wearing the mask.
Dr. Raj, thank you very much. It just seems like we have an abundance amount of participants that are coming in today. They just keep blowing this thing up, and we're so happy that people are coming in to listen to you.
That's great. No, I love it. I love it.
They are utilizing the Q&A chat feature to be able to supply these questions and everything. So folks out there, keep it coming. We're glad you're participating and engaged. Richard has a question pertaining to the Pfizer vaccine. He says he's going to get it on Saturday in Michigan, actually across from the Pfizer plant. And he wants to know how soon after the second dose would it be safe to travel, let's say by SUV to Colorado to see the grandkids?
I love that question. So, Richard, I actually did a lot of my training in Michigan. I did my sleep medicine fellowship in Henry Ford. I did some of my residency in Grand Rapids. So I know where Kalamazoo is. So, good for you, Richard. Okay. So anyways, so the answer is this. When we talk about both vaccine, let's talk about the Pfizer vaccines. There's 2 doses. They are looking at the data about the Pfizer vaccine and have actually shown that even after the first dose, you give it maybe a week or so, you will start making some antibodies. By all means, I'm not saying stop there, but I just wanted everyone to realize that it's imperative that you even get your first dose of the vaccine. It's imperative you get your first dose and you can get some protection off that. So for the Pfizer vaccine, the one I got, the one Richard's getting, you get the second dose 21 days later. Then after the second dose, he's asking when is it safe, when to get the antibodies. I'm going to answer that personally. So what happened is that here at USC, one of my partners is doing a research study, and they got a grant to do antibody testing. They got these little kits where they stuck my finger, and I think my partner didn't like me because just jabbed me in that finger. I'm like, why does this hurt so much? But this antibody test is kind of like a yes or no. It's not a quantitative antibody. So everyone's going to ask me, what do you mean by quantitative antibody? I mean that quantitative tells me how many of the antibodies you have. The test right now is just a yes or no answer. And that's what scares me. You know what I mean? Is that if your antibody test is positive, if you only have one antibody, you know what I mean? That doesn't mean you're good. If you are having abundance of antibodies, then that's a whole different story. But what I can say is that I took the test around maybe a week after I took the second dose, and I know I was negative. How do I know? Because part of my partner's study, she pricked me really hard before I got the vaccine, and I was negative. So I knew I was negative before. So it really was a great feeling when I saw the positive result. It makes you feel confident. It makes you feel safe. It's a great feeling, everyone. So get the vaccine. But I am making antibodies. So the answer to you, Richard, is that, remember, a vaccine still means you can get the COVID-19, you can get coronavirus. A vaccine still means you can pass it on to others. All a vaccine does is give you those antibodies. So remember, just because you're vaccinated, you're protected, you won't end up on the ventilator, you won't see me in the medical ICU, but you could still get it and transmit it. Don't forget that. And that's why I love your question, probably more than any other question, because what is the role of a vaccine? The role of a vaccine, simply put, is please don't let me die. That's the role of a vaccine. But you could still get COVID-19, you could still have mild symptoms, you could still pass it on. So you always have to put in perspective, why are you traveling, why are you going there, and you could still pass it. And anyone who gets a vaccine, you know what I'm going to say, you still have to do the big three. What are those big three? Good hand hygiene, social distancing, wearing the mask.
Awesome. Follow-up question. You got Richard going now.
Richard's pumped.
He's almost there with the grandkids. So follow-up question is, he's also a type 2 diabetic.
Oh, sorry, Rich.
Will the vaccine spike his levels?
No. So if we're talking about his glucose levels, his hemoglobin A1C, the answer is no. I think that this tells me you are my target audience. If you're a type 2 diabetic, if you're like me who could lose a little weight, you know what I mean? I think that you need to get the vaccine. And I'll just say a little tidbit. I've been in the ICU quite a bit here at USC County and the private side at Keck. And, I would say that the people that I've noticed get the worst outcomes when it comes to COVID, it's no joke, it's minorities. They get it the worst, and it makes me tear up all the time. And number two, overweight. So I'm going to start pointing fingers. If you're an overweight minority out there, do something about it, because I'm not writing up a research paper. This is just my observations that I've seen in there. And hopefully this is going to provide you good motivation to get the vaccine and stay in shape. And don't get that, what do they call it? The COVID-19 pounds. Don't get the COVID-19.
Awesome. Great things. And so you mentioned, seeing patients in both settings. What would you recommend for somebody if they get COVID-19? When should they seek medical assistance? What signs should they look out for? And maybe take us through that type of experience of, going to the hospital or seeking care in the home.
Yeah. So there's different prongs to this answer. So, now more than ever, being a lung doctor, that, all my patients with this outbreak just skyrocketing, they've been asking me all the time, I think I got symptoms, I'm positive, what should I do? Where should I go? And, I would put it this way. Well, the first safest thing to do, because there are individuals who had a high risk exposure and there are people who test positive, and that's kind of a little bit different. I think the minute you suspect yourself for having a high risk exposure and you're scared to get tested, but you had a high risk exposure, my answer. Stay at home, isolate, quarantine. You got to quarantine, And the question now becomes, well, Dr. Raj, how long do I quarantine if I had a high risk exposure? Is it 14 days? Is it 10 days? Is it 7 days? And I think this is one of the problems during the pandemic as a whole, is that it's confusing. Isn't it, guys? Isn't it, girls? Isn't it confusing? There's so many different guidelines. And, the CDC are saying 14 days, but it could be 10 if you decide to get tested afterwards. But usually a test comes back in 2 days and it's 12 days. Why not stay for the full 14? So there's so many different things. So my advice, to keep it simple, if you have a high risk exposure, just stay at home for the 14 days, which is what I call the gold standard. If you test positive, well, it really depends upon your duration of symptoms. When were you symptomatic? When were you not symptomatic? Because if you stay at home for 14 days and you're still having fevers on day 12, don't leave quarantine. That sounds like a horrible idea. So this is where you have to get your healthcare professional on board and let him or her know that, hey, I tested positive. I'm still having extended symptoms. How long should I be isolated? How long should I stay in quarantine? Now we're talking about symptoms and what should I do? So if someone comes in and you test positive and you're just having mild symptoms, if you're just having mild symptoms, you know what I'm going to say, crowd. What am I going to say? Stay home. That's the jam right there. It's going to be protect yourself, protect others, stay well hydrated. You know what I mean? Do the simple things because you're going to be asymptomatic or mild symptoms. And that's what most people are. They're mild symptoms or asymptomatic, you know? Now, if you're at the point to like, you know what, Raj? What? I think I'm a little short of breath. I'm not sure. It could be anxiety. It could be other things. What do I do? Well, the first thing you do is contact your healthcare provider because many of them are going to give you suggestions if their healthcare system is associated with an emergency department or some kind of setup like a tent that's going to be outside where they help triage. So I would always contact your provider. So let me talk about what happens here at USC. If you come to USC and you have mild symptoms, we have an area, tent set up outside where we'll decide that, you know what, you have mild symptoms. You don't need to get admitted, but right now there is an FDA approved monoclonal antibody. Now, this is what I talked about when we talk about passive immunity. So monoclonal antibody is a one-time infusion, one time. And we're giving you antibodies against COVID-19, against novel coronavirus. And it only got FDA approval for people with mild symptoms who are not on oxygen. And so what we do is if you go to the ETC, which is what the Emergency Therapy Center, that's letters we use here at USC, we'll give you the infusion and maybe send you home. Or right now in my office, we have it arranged where we could send individuals to your house to give you that antibody. Now, I don't know if this is going to apply to everyone around the country because of insurance, availability, so many things, but that's when we use the antibody, not on oxygen, mild symptoms going home. If you get admitted to the hospital, you don't get to see me yet. You don't get to see me till you go to the ICU. If you're on a regular medical floor and if you're requiring low levels of oxygen, you may have like a COVID pneumonia because they shot an x-ray. There is one FDA approved drug that we may consider giving you, and it's called remdesivir. Now, remdesivir is an antiviral medication made by Gilead Pharmaceuticals, and its claim to fame is not reducing mortality, improving survival, but it improves your symptoms. And it's given through the IV. We give it for 5 days, and the contraindications, don't you love? I always give the whole.
The full effect.
Yeah, the full effect. It's people with renal failures. You don't give it people with renal failure. You got to watch for your liver enzymes. So it's an inpatient drug because we got to monitor these labs when you're in. So you're going to get remdesivir. Let's say that you get worse and they first put you on the regular floor and then all of a sudden your oxygen saturation starts going down. You're feeling more short of breath. You require more oxygen or different ways to help you breathe. Then you see Dr. Raj. And that's never see Dr. Raj. It's never good because that means you're going to move into an ICU setting. And when you're in that level of oxygen requirements, or if I put you on the vent, which I never want to do, then the best medication to give is steroids. Now, before I used to just say what the best steroid is, which is dexamethasone. Reason why, there was a study in the UK that showed that in patients on ventilators and requiring oxygen, it reduced mortality. But there are smaller studies now showing that different names of steroids, solumedrol, prednisone. They're studying to see if any steroid can be given at even higher doses. So those are things you're going to get when you go to the medical ICU. And the last thing I'll say before I'll answer another question is the hottest topic right now in COVID treatment, which is this rheumatological drug called tocilizumab. Now, tocilizumab has a brother called sarilumab, and I probably hacked up the name over there, but both these drugs work against a protein called interleukin-6. Interleukin-6 is a protein that really revs up your immune system and gets the inflammation going. When we started using these interleukin-6 inhibitors in the beginning of the pandemic, we came out of the gates hard using it, and data says, nah, they don't work, they're expensive, forget about it. Then all of a sudden a study came out about a week ago. It's not a peer-reviewed study, but it showed that in individuals who get this steroid and tocilizumab, that it may actually improve survival. It's not peer reviewed, but I could tell you that all of a sudden around the country, especially here in Southern California, where we're getting hit pretty bad, we are now approving this interleukin 6 inhibitor, tocilizumab, sarilizumab, more than before in order to help you. So this is exactly how I view someone who gets COVID. Those are going to be your choices. Did Sean, did that answer the question?
I think it did. Very good. Thank you very much. As you know, many of our participants this evening have sarcoidosis. And one question came in: understanding this disease hypes up the immune system in patients with sarcoidosis. The question is, does this give the patient an upper hand in fighting COVID-19?
Oh, that's a great question. You would think so, just one dimensionally.
Right.
But the answer is no. I mean, it's better not to have sarcoid. It's better not to have lupus or rheumatoid or any of these diseases. And the way I'm going to cascade my answer is going to be this. I mean, the number one question that people with sarcoid ask me or ask my wife, the rheumatologist, is, Dr. Raj, should you hold my medications? Should I hold that methotrexate? Should I hold the Imuran because of the fact that, you know what I mean, it's immunosuppressing me? And the answer is no, because we do those meds because we want to keep your inflammation low. We know that patients with sarcoid, you can get really inflamed. Those, let me say the word, non-caseating granulomas are in every single organ in the body. When they get really inflamed, they cause a lot of damage. So we want to keep your inflammation down by using those meds. And we know that if individuals with sarcoid or many rheumatological diseases, if they're not on their immunosuppressant medications, they will get really hit hard if they get infected with novel coronavirus. So the inflammation you're talking about doesn't help you, it hurts you, which means stay on your medications.
Awesome. Awesome. Words for the wise.
Yep.
Are there any statistics on how sarcoidosis patients who have contracted COVID-19 have fared, and what were their treatment protocols?
Oh, great question. So, I kind of saw one of the questions just kind of creep up on the Q&A, and I'll kind of address that along with yours. So when we talk about sarcoid medications, the thing that popped up was, oh, they stopped my meds. So it depends. So if someone does not have COVID-19, we keep them on the medications. If someone develops COVID-19, and I'll be telling you, I've had sarcoid patients got COVID-19. My wife's got many patients that develop COVID-19. Only then do we stop the meds. So there's no way you're going to convince me if you're sick, yeah, just keep the methotrexate going. Oh, just keep the Humira going. Keep the Remicade going. No. If you're infected, then we stop it, but if you're not infected, keep it going. So hopefully that addressed that question. But, I will tell you this, is that my sarcoid patients, when they come to the hospital, I mean, the wonderful, beautiful thing about our lung center at USC is that they'll definitely contact my office. It contacts me. If not myself, my fellows, my residents, my team will see you. I always will say, if possible, I will try to stop the meds. Now, let me say this very, very clearly. There is one med that you cannot stop cold turkey. Does anyone take a guess what med that is? Prednisone, steroids. I mean, you just can't be like, oh, I got COVID, I'm on prednisone every freaking day and boom, stop. You'll die. You just can't cold turkey prednisone, And the reason why I'm joking about it and laughing about it, because I hear it all the time. My wife tells me, so I got to make sure when I say stop the meds, I mean these other cytotoxic meds. So what happens is when you come to the hospital, if you're on other cytotoxic meds, I definitely would hold that. And I use the same algorithm. I treat my sarcoid patients the exact same way. Number one, don't get admitted. Try to stay at home. I definitely have used the monoclonal antibody in my patients who didn't require oxygen when they go home. And you know what? No side effects, no bad feelings, and it makes them feel a little bit better. If they get admitted to the hospital, I watch them carefully. I put them on oxygen, not to keep them up to 100%, because one thing that we learned about COVID patients, your oxygen saturation does not have to be 100% on your pulse ox. If that's what you're being told, I'm not ripping on other people, but that's just wrong information. Most of my COVID patients, regardless of where they are ICU or just floor, I'm happy when you're hanging out around the low 90s. You don't have to be 100%. If you're symptomatic and low, that's another story, but you don't need to be 100%. If they're on the floor, I have used remdesivir in these patients. I think it kind of works okay. The reason why I say think is because it's not a drug that you get infused with and like, yeah, thank you, this works great. Its claim to fame is that it reduces duration of symptoms, and it's not really a feel-good type medication. And then, of course, the worst part is maybe a few end up in the ICU, and so far I didn't have to intubate, put any of my sarcoid patients on ventilators, but that's always the day I fear.
Wow. Yeah, I would totally agree with that. Is there anything you can tell us on the latest with the COVID-19 testing? Are the home tests reliable? How should we approach that?
Yeah. So, this goes back to, if we could go back in time or after this pandemic and see what were some of the do's and don'ts. The biggest thing is, I think it's been really confusing for everyone, and confusing for me and confusing for my patients, just terminologies we use, such as the patient is asymptomatic. No, that's pre-symptomatic. What does that mean? The testing, you know what I mean? It's not as simple as saying testing anymore, right? Testing means, is it an antibody? Is it an antigen? Is it going to be a PCR for the messenger RNA? It's so confusing, and I don't blame patients for not knowing what test to get, because it's really not their job. But the way we present things, it's very confusing. So the answer is this: is that let's start on one side. If you were to put me in a corner and say, what is the gold standard diagnosis? It's shoving that stupid thing up your nose and getting PCR. You know what I mean? You're looking for the messenger RNA of the virus. You know what I mean? And the problem with repeating that PCR once you're positive is because it can still remain positive for a very, very, very long period of time, because the virus could be dead, but there could be parts of the virus, parts of the messenger RNA up in that nose. So we don't really retest based upon the messenger RNA nose shove. Then there are antigens. Now, antigens are part of the virus where we could create a test and say that that part of the virus is still in you, per se. And antigens' claim to fame is that you could test antigens in many, many different ways. You could shove up the nose, you could do saliva, you could do blood work, you could do all these things. And a lot of this home testing out there are looking for antigens. But of course, with any test, especially these antigen tests, that's what you just said, false positives, false negatives. And that's where it causes more confusion, especially now that there are new guidelines that say that, remember we talked about the asymptomatic person who's in quarantine for 14 days because of high risk exposure. If you take a test and it says it's negative, well, then you can go out in maybe 10 days. But once if it's a false negative, you know what I mean? And if it's a false negative, now you just go and infect more people. So it is true, whoever asked this question, that all these tests do have a false positive, false negative. There are so many different types of tests made by many different manufacturers. It's not standardized. And this has been happening throughout the pandemic. This is not new. And then there was a test I took a picture with, if anyone follows me on Instagram, where it was an antibody test on a finger stick. And I didn't realize everyone thought how cool that was. But yeah, now we're looking for the antibody. We don't check for antibodies for acute disease. You know what I mean? If you want to know if you're actively infected, shove up your nose and get a messenger RNA. Antigens are kind of like the hot topic for home testing to see if you're going to be infected or not. But the antibody test seems to be really popular now because did the vaccine work? You know what I mean? And so what they made me do, I'll only talk about me. I was infected with COVID-19. I was, including my wife and my 3 kids, in end of July, beginning of August. And when the vaccine came out in December, there was a rule at the time saying that if you were infected with COVID-19 and you have the antibody, you can't get the vaccine. So before I got the vaccine, they tested me and I was negative. And that, number one, it means that many people were asking, how long do your antibodies last after you're infected? Some studies show 6 months. Now there's a few studies say 8 months. Man, I got infected in August. My antibody went away in December. That's
Wow.
4 or 5 months.
Wow.
So, I was infected, it didn't protect me that long, but because I was negative, I got the vaccine. And then they pricked me again for the antibody after my second vaccine, like I told you, and voila, I'm making antibodies. So I think that this is going to be important in my rituximab patients. Remember, we were talking about rituximab, where that drug blocks B cells from making antibodies. I think patients on rituximab, it'll be really, 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 really nice to know after you get the vaccine, are you making those antibodies? So that's where I think it's going to play out.
Gotcha. Gotcha. Relating to that, Elizabeth had a question about a saliva test because college students are taking these. What's your
Sure.
thought on that?
Yeah. And so, I know we're joking about shoving up the nose, but, basically if you come to see me at USC and how do we test for gold standard COVID-19, it is a combination of a buccal swab, which will actually take a Q-tip, then we'll do the side of your mouth, take the same one, I'm not kidding you, shove it up your nose, and then you spit in a cup. So all three they're checking for the messenger RNA. I think the key thing is, what are you testing for? Those are not antigen tests. Those are looking for the messenger RNA, but they're trying to get everything around here: saliva, buccal swab, up the nose. So I have nothing against that if they're checking for the messenger RNA. But some of those tests can check for antigen. You just need to ask your college what they're testing for. All the tests at the airport, these rapid antigen tests, that's what they're doing, rapid antigen. I don't believe they're checking for the messenger RNA.
Gotcha. Gotcha.
Yep.
Makes sense. Makes sense.
Mhm.
This is all making sense to me. I appreciate it.
That's great. I could see all these light bulbs kind of like, yeah, I got it,
Yes. Yeah. Definitely. Well, Kathy has a question,
Sure.
and her question is with liver function testing high, is it still okay to get the COVID test?
Oh, no, definitely, definitely. Of course, when you have, of course, the question is, why is the liver enzymes high? All these things factor in.
Sure.
But I will say that if you have elevated liver enzymes or liver disease or, God forbid, cirrhosis, definitely let your physicians know, because there could be certain medications that you should definitely not be on at all. And by having liver damage, it really weakens your immune system. Not just a little liver irritation, but you have liver disease. Your liver is one of the biggest makers of your immune system. So definitely individuals with cirrhosis are a higher risk. So to answer your question directly, no, you could definitely get tested, and you should definitely get the vaccine as much as anyone else, if not more.
Gotcha. Gotcha. Thank you for that. I think this is probably one that would benefit everybody, and we'd love to know your opinion. If you could give any advice to sarcoidosis patients during this time, what would it be?
Oh, wow. I would say now more than ever. Of course, you're asking the person who just loves my sarcoid patients more than anything in the whole world. I want all the sarcoid patients just to come together. I want them to really, put their head down and power forward through these tough times. It sucks to be lonely. It stinks not to be able to play with your grandkids or to see your friends, because my sarcoid patients come in all shapes and sizes and ages, and it's hard. You know what I mean? And some of my favorite sarcoid patients, and I do have favorites, I'll be honest, they're at home wearing oxygen, they're older in age, and they just feel like no one's out there. And one of my favorite things to help my sarcoid patients, there are groups, at least here in Southern California, that they're volunteer groups where they will call my patients just to say hello, just to drop things off. And I could try to give you some of the names of some of these websites here in Southern California that are just doing amazing, amazing things for free to help, some of the older patients or patients who are really, debilitated based upon their problems, to keep them engaged. So my wish is them to, put your head down. There is light at the end of the tunnel. Be extra, extra cautious. You know what I mean? You don't want to see me in the ICU. You don't want to be in the hospital, especially because not many people know sarcoid. And now you have a strange disease, COVID-19, that's always throwing curveballs. The admitting doctor's like, sarcoid, what's that? What do I do with these meds? What is this? What do you mean? So it's not easy when you go to a hospital and are not with a doctor that you're familiar with. So home is the best place. And of course, everyone's going to read my mind. get vaccine, get vaccinated.
Yeah.
That's what I wish.
Yeah. Yeah, and I would echo what you're saying. It can be a depressing state to be able to go through that and think that you're by yourself and you're trying to manage through this disease. One of the things that we love at the Life and Breath Foundation is trying to make the connections and be there and be able to connect patients with other caregivers or people. And sometimes you just need to listen, and be there. So we're definitely open. Please reach out to the Life and Breath Foundation. Our website is www.lifeandbreath.org for more information, and we'd love to be able to reach you. Dr. Raj, again, just a fantastic opportunity to share with you this evening. How is your family doing, by the way, and the kids and everything as you finished up and navigated through 2020?
Well, Sean, thank you for asking. And, we're doing all right. I'm not going to lie to you. My innate personality is always going to be positive. I can't help it. It's just who I am. But it's been tough for everyone. Me and Sean were talking behind the camera. Sean, how many kids do you have? Raj, how many kids do you have? I have 3. I have a 18-month-old. Her name is Sadie. I have a 5-year-old. His name is Aiden, and he has autism, everyone. He's special needs. And, it's been tough on him in particular because the fact that, doing Zoom chats and teaching an autistic kid this way, it's not easy. It's hard. And, as a dad, I have to be patient, and it may seem impatient over here during Zoom chat, but, I get a little frustrated. I get home, you know what I mean? I want to take my shoes off and watch the Laker game. Yay, Lakers. But I can't do that. There's a whole nother job. And then there's homeschooling, and all that falls on my wonderful wife, who's also a doctor. So it's been really hard. But and I have my 7-year-old, her name is Mina, and she just started getting into basketball. And of course, that's it. No more basketball for a while.
Exactly.
So it's been really hard. But I will say this is that right now I'm working at Keck Hospital of USC, but lately I've been doing a lot in County Hospital. And I am just so proud to work at County. They're just all the horror stories you hear, those wartime stories, that's what County's going through. And I'm just so proud of them. And who is them? It's not me, the doctor. It's the nurses, the respiratory therapists, people who clean the room. No one ever gives them a shout out. You know what I mean?
Right.
And I also want to let everyone know that I have these amazing internal medicine residents who get paid absolutely nothing that are awesome. And of course, my pulmonary critical care fellows that I train, they're also amazing. But I don't know, Sean, I sense good things. I think that my crystal ball that always seems to be broken, if I take it out right now, I think if we do this conversation, somewhere around, June, July, I think we both will be smiling in a good way, not in a fake way. I do sense a couple good things.
Yeah, I would also agree with you, and I have that outlook that is thinking that 2021 is going to be much better than 2020. I'll keep smiling and looking forward. But I wanted to take this time to, again, thank you very much, Dr. Raj. We greatly appreciate you spending the time with the Life and Breath Foundation and the many people that you support. And the information is very timely regarding the vaccines and COVID-19. And we really appreciate the enormous amount of information that you've been able to share this evening. It has been a situation that has been confusing a little bit. You've really cleared up a lot, and I've taken some notes, and I'm sure some of the other people too. But this has been recorded, and we're gonna share, and we'd like to make sure that we can connect people to your podcast and take advantage of the just enormous amount of information you continually share that's very timely.
Oh, thank you, Sean. And I'll just do my sign off on my side, then we can say goodbye. Everyone, thank you for being part of the live taping of the Dr. Raj Show. I truly mean this was a special day, a special moment, a special hour. I hope everyone who likes the podcast watches this live video. I'm not joking. I'm smiling the whole time. And that's why Sean loves my hand motions and doing everything. And thank you, Sean. And thank you, Life and Breath Foundation, for letting my show be a part of your life. And I can't wait for our next adventure together, Sean. I can't wait to do more with your patients and your audience.
Happy to be with you today. Thank you very much. All right, everybody. Dr. Raj, again, we appreciate it. This was a fantastic opportunity to spend with you again. I hope to speak with you very soon and wish you nothing but the best to you and your family.
You're welcome. You know what? I'm not lying to you. I know we're not taping. I had a blast. That hour just boom.
It really did. It really did. Well, thumbs up from all the participants that are on the line and everything. And we look forward to seeing you very soon. And stay safe and stay healthy.
All right. Thanks, bud. Take care.
All the best.